Well, thanks. Maybe as a last question to open it up to anyone and all of us to comment, in this space, what do we see as kind of the future strategies? We've spoken about chemoimmunotherapy. We've spoken a fair amount about BTK inhibitors. We've spoken about ways to potentially sequence that. And then we touched briefly now on venetoclax. But as you look at the future, what do you see as either new agents coming or, shall we say, strategies that are going to be the future to manage patients that would have relapsed or refractory Waldenstrom's? What do you think?
I think we have just to look at the other entities. So the development in, follicular lymphoma, mantle cell, diffuse large B-cell lymphoma, and I think Waldenstrom will be not so much different. And I think timely, fixed duration, chemo-free approaches will be the future. And, there are already great possibilities we have with BTK inhibitors, non-covalent perhaps, or not perhaps ibrutinib, or who knows, but perhaps even Zano plus BCL2 inhibitors. And I think what is really emerging are the bispecifics everywhere. I think the data in Waldenstrom are still very limited, but when we look into the future, I guess that they might also play a role in Waldenstrom. Right.
Monique, what do you think?
Yes, I do agree, and I think I forgot to mention that in the previous question, that in that sense clinical trials are really important. So if you think about relapse treatment, also for patients, ask if there's perhaps a clinical trial open where you can participate, because we really need those trials to answer these questions in the end. So in the Netherlands, we did do we asked many patients more than what their preferences are for treatment. And in the Netherlands, they answered us, of course, it should be a very effective treatment. That's their key, without too many side effects, and they favor a limited duration. So not endless treatment, but a fixed duration treatment. So I do completely agree with Christian that we do need, I think, combinations of non-chemo drugs, perhaps with a fixed duration, and we try to figure out how to do that, because with BTK inhibitors, we do know that we can't stop them, because patients do relapse quite soon after that. But perhaps if we combine things that can improve and can entail fixed duration treatment for them.
Thanks. Sheeba, you've done some stuff in the immunotherapy space, vaccines and the like. Do you see those having a future? I mean, Christian touched a little bit on bispecifics. Where do you see those kind of fitting?
So I think the vaccines may be best suited to a lower burden of disease. I think it's difficult to use, to expect someone's immune system to respond to a vaccine if the disease is for example, in a relapsed situation, but perhaps in the smoldering phase where there's a lower burden of disease, or perhaps as sort of a consolidative approach after the disease has been well controlled, to try to hopefully use the immune system to consolidate a response. I think that those would be the two areas to look at.
Right. And Jorge, your group has really kind of led the way on many of the novel new drugs that we've been using in this disease. What do you kind of see on the horizon, either that we should know about because they're sort of here, or that we don't know about because they're still coming? What do you see as kind of the next potential big thing?
Yeah, I mean, I think we can look at three potential ways to go. I think one of the ways to go is try to come up with combinations, right? Looking at BTKI combinations for a fixed duration regimen, right? So I think that would be valuable, for example, in the frontline setting, in the early relapse setting, because, I mean, covalent BTK inhibitors are still one of the most active agents we have in Waldenstrom's. So combining them, doublets or even triplets with fixed duration could be a reasonable way to go in that setting. The other avenue of research, in my opinion, is other targeted agents, kind of exploiting a little bit more BCL2 inhibitors, We do have a number of pathways that we are planning on targeting in the next over the next few years, and that will be, in part the non-covalent BTK inhibitors, which I think are very important with pirtobrutinib and nemtabrutinib coming up. But also we have novel BCL2 inhibitors. We do have IRAK inhibitors, HCK inhibitors that could potentially, do something, right, for this disease. We have a MALT1 inhibitor, maybe a couple even that are being developed currently, and some of them will make their way into Waldenstrom's. And then we have the other big third branch of research in Waldenstrom's, that is immunotherapy, right? So we actually have ongoing clinical trials with antibody drug conjugates. We do have an kind of a phospholipid drug conjugate with a radioisotope that is, nationwide running, accruing currently. We do have the BiTEs, as Christian mentioned, that I think are coming up very nicely. The CAR T-cell program is going to start a big, worldwide CAR T-cell clinical trial is about to start in that setting as well. So yeah, plenty of options, I would say, for the future.
Well, I certainly think, this is the exciting time because, as you mentioned, plenty of options, lots of effective therapies, working out how to utilize them best and what combinations is kind of the key, but also bringing in some of those new drugs that you mentioned, Jorge, I think is kind of critical. So thank you very much to the panel. Really appreciate people's thoughts and insights. Thank you.